this, but the doctors, just like all of us, switched over to these electronic methods without really understanding and without knowing the connectivity and knowing how much to use and what, I mean, we can be inundated by information, and the doctors especially, because of so much material comes through to them. How, first of all, how do they edit things out, and how do they personalize it? But one of the huge issues to me, and that's an interior design issue, is the way doctors and their digital technology are placed in relationship to the patient. I mean, it's like, come on, the guy turns his back on me while he's looking up my case.
I was the patient in a video that taught physicians how to interact with patients that Cheryl Herbert demanded.
I mean,
yes.
it's so designing that room where that takes place and keeping in mind that it is, after all, about me as the patient and not about that technology, because I think we can get so involved in the technology that we're not going to remember that there's that little me shaking in my boots because I'm really afraid what this doctor is going to tell me. So are we getting to the point where some of these initial issues that we have inherited from the switch to technology are getting solved in an interesting way? Or Roz, I mean, what do you see?
Well, so I will first say that in the evidence-based design movement, we know where we have a vast body of knowledge, and then we know where we have voids. And one of the areas where we have voids are in communication between patient and clinician, between patient and family, between clinician and family. So we've always known that there's some disconnects, and we know little about it. So when it came time to really begin to understand how the built environment would improve communications, technology hadn't quite come into play yet, but one of the first measures in the effort to improve safety in care delivery was to put a sink in every room. And like technology, you know, sinks are tied to a mechanical system that comes through the walls. And where do you put a sink but you put it on a wall? And Dr. Roger Ulrich, who is the guru, did lots of studies and said that the only way we're going to get compliance is to put the sink on the inside of the door. Trip the physician, the nurse, anyone who comes into the room, and get them to wash their hands and let the patient be able to see them, and then teach the patient to ask the physician or clinician if they've washed their hands. So the sink goes in, and what happens is, you're my patient, I walk in and I'm washing my hands. So now I can't talk to you. But you want to talk because you've been waiting hours. So what happens is they don't wash their hands even though the sink is right there. And so we began to look at how to improve that relationship, and it was an ED design that we did at Yale New Haven Hospital, and I begged if I could just take the sink and instead of putting it here, if I could just put it on an angle, and this way when I walked in I could not be a Gumby, and could we get improve the occurrence of washing hands and beginning the communication process. So then comes along this technology piece. And in all fairness, most physicians will tell you that they're trained to deliver a message, not get emotionally involved, get in and get out. And so this idea of eye contact becomes difficult, but now we've put something in front of them that they're not familiar with. And they've got to ask, and they've got to type, and so this was a disaster, and we didn't give them the right chairs. So they're also now on this counter with their back. And when the first electronic medical records came out, it would take two people. There'd be a nurse and a doctor. Well, I don't know, is it that box? Is it that? Tell me again, what did you, And so this little dance would occur in this learning curve. Well, I think we're a little better now, and that we have clinicians who maybe feel a little bit more comfortable, but we still haven't gotten the design down right. So some of it is the ability to be tethered to something, thank goodness for wireless now, so we can untether from the wall. We have to be able to get to an ergonomic understanding of how one communicates. There's a wonderful physician at the Yale School of Medicine who taught me that the stethoscope is actually designed a certain length so you get into personal space so you can smell and get really close and hear things a little differently. So how do we allow technology to be shared and be personal? And so how do we begin to understand as designers how we throw old furniture out and create new furniture? And one more crazy story, I got really upset for a new hospital that opened up and was completely covered, every horizontal surface was covered with hardware, and I couldn't understand what was going on. So I actually picked up the phone and called Epic, who is the major provider for most electronic medical records, and I said to them, "What did you do to this hospital? This is terrible." And they said, "Oh, we're not a hardware company, we're a software company." And it occurred to me that although they had worked really hard on developing the electronic medical record, they too did not consider the environment. And so the pushback is that it's a multidisciplinary conversation, and we need to get to the hardware providers to know that the kind of computer I use at my desk in my office or the laptop I use on my knee on my sofa at home is different than what a clinical provider needs. And I think it's not going to be a laptop and it's not going to be a tablet. It's going to be something that's wearable, and it hasn't been developed yet. You all need to scream louder, and we'll be right there by your side to fix the problem.
I would
So
love
I've
to
just said a
chime in.
lot.
Is it
Yeah.
So